Hi, my name is Cecil Walker.
And I'm Adam Frower.
And this is Possibilities. And today we're going to be talking about a way to maybe potentially improve, the mental health treatment process. And that way is maybe through reconsidering diagnoses, whether they're useful, whether they're maybe just a formal step that we're taking that is or is not getting us somewhere. To kick us off, I guess just to lay out the context, Adam, what's the argument for diagnoses in the first place? And then maybe we can see where we go from there.
Yeah, so I think we have to kind of think historically about psychotherapy and how psychotherapy came about. And it really followed the trajectory of medicine, right? And medicine is really based on identifying what the problem is, doing some assessment about how the problem is impacting typical functioning. And then from there, we know what kind of treatment is useful in order to alleviate that problem and get someone back to full health.
Right.
So if we take that model into psychotherapy, the same kind of idea is someone comes in and there's something inherently wrong with them. There's a problem that they have. Typically, a diagnosis is a series of symptoms, right? We say, if you experience these symptoms, you have this diagnosis. The idea then is, once we identify what that diagnosis is, then we know then how to effectively treat it. We eliminate those symptoms or we make better those symptoms, and therefore someone returns to full health.
Mm-hmm. And for the people who might say this is a necessary step in the treatment process, why is that? Why is this helpful? Why do they feel we need to walk through that step to actually make some progress?
Yeah, that's a good question. So I think there's a couple of answers to that. One is, in an era of third-party payers, insurance, right?
Mm-hmm.
Insurance wants to know, what are we paying for? What's the problem, right? If I go to the doctor and you have a broken leg,
Mm-hmm.
then I know, okay, I'm going to fix the broken leg. And typically this, we put a cast on it and we
Mm-hmm.
put a cast on it for such and so long, and then it's fixed. And the insurance company knows, okay, how much do casts for legs cost? If they're on for such amount of time, how much do we pay for that, right? So one argument is insurance companies would have a better idea of what do we need to pay in order for this problem to be eliminated. That's one problem, or one approach. A second reason that this might be useful is we also live in an era of evidence-based practice, right? Much like modern medicine, it again is, there could potentially be an array of possible treatments. Which one's the best? Which one has research that says it's going to help people heal the quickest, right? So psychotherapy has also kind of adopted an evidence-based approach. So which approaches work for treating X problem? If we don't take that scientific approach of A problem leads to B treatment, which leads to C outcome, then we don't really need a diagnosis so much. But if we do, it helps us to say, okay, if X is the problem, what treatments are the best treatments? Is it cognitive behavioral therapy? Is it psychoanalysis? Is it, behavior or solution-focused therapy, right? So if we know what the problem is and we know what effective treatments fix that problem, that's also an argument for why diagnosis might be useful. I think, and a third argument, there's probably lots more, but this will kind of help us boil it down a bit, is there's an ethical mandate that we do no harm, right? We don't, and if we don't know what the problem is, if we just intervene willy-nilly, how do we know that we're not going to do harm to someone? How do we know that we're not going to intervene on something that wasn't a problem to begin with? And so there's an ethical mandate that says we should know exactly what we're doing and why we're doing it. And so I think those are some of the major arguments for why diagnosis might be useful.
Yeah, that's really helpful. I think you're filling in the context here a lot. And if I were to sympathize with the perspective of a client too in therapy, maybe this is your first time in therapy, maybe this you addressing your mental health issues in this overt way is very new to you, and someone says, oh, you have this diagnosis, here's how we treat that, here's what that looks like, here's what we know all about that, you're in good hands because this is familiar to our field, to my expertise as your clinician. I imagine that'd be comforting. You know, there's some comfort in knowing that what you have is a known thing, that this is something that someone could have knowledge on, rather than it being a nebulous thing that, you know, it's whatever. We'll see how we can do something about this.
Yeah, I think it does give some reassurance to, like, what I'm experiencing is a normal thing to experience. If it has a name, other people must also have experienced it. This mental health provider must know something about how to deal with this thing.
Exactly.
And so I think you're right. I think there must be some comfort in just, okay, what I've got is understandable.
Yeah, exactly. If you went to see your doctor and they said there's no name for the thing that you have, that's a little concerning. That's a little discomforting, I think. So this is why it exists. This is how it's being used. This is why it might even be potentially helpful. These are the arguments for it. Before I even get into other ways that might be helpful on this similar topic, why might it not be helpful? What is it potentially hindering and getting in the way of? What might it be limiting?
Yeah, I think this is a really important question. And I think in some sense what we're considering here is, and I like the way you phrased it, because what is it limiting? And I think given the name of this series, right, possibilities, is we could potentially be limiting possibilities. And what I mean by that is what we know about, particularly, let's start with neuroscience, is that when I feel negative emotion, when I feel sadness, when I feel depression, when I feel anxiety, when I feel anger, when I feel all of those kinds of things, then my brain narrows out possibilities, right? We begin to think more and more linearly. If I do this, that's the only way that I could feel better, right? And all of the other things, this is why one of the symptoms of diagnosis, if we go with diagnosis, is you used to enjoy things, but you're no longer getting enjoyment out of those activities that you previously enjoyed, right? And I think that speaks to this idea of our brain, in essence, starts dropping possibilities of things that are going to bring us joy, bring us happiness. And so what ends up happening is that if we buy into diagnosis, right? If we buy into things like depression, if we buy into things like anxiety, we limit and we say, if you have depression, if you have anxiety, you function within this range of possible behaviors, and that's the limit of the possible behaviors that you have access to. And I think one of the things that the counter argument for that is, if we can help people to begin to feel positive emotion, happiness, joy, satisfaction, excitement, one of the things that we know is that our brain starts to expand, and things that weren't possibilities before might all of a sudden become possibilities, right? Most often this comes up with suicidality. If I feel suicidal, I have narrowed down all of the possibilities to the only thing that's going to help me feel better is to end my life. That's how the pain, that's how the suffering is going to end. And the reality is, if we start to talk to somebody who is suicidal about happy things, about joys, about future plans, all of a sudden things that weren't possibilities before become possibilities. And so I think if we stick with simply looking at things as the diagnosis, we limit the range of possibilities for people, and we pigeonhole them into, you can only behave within this range of behaviors.
Yeah, I really like how you put that. That was very well put, that it removes those possibilities that are actually really crucial at that point for someone who's going through whatever this mental health difficulty is. And I think what just kind of overlaps with that. What happens simultaneously in removing those possibilities is it kind of relegates treatment to something almost impersonal, something. I see you have depression. That's, going by the textbook, here's how we treat depression. So now I'm treating depression instead of you. Instead of what's going on for you, what's very personal and meaningful to you, what are the things you're experiencing, and what are you trying to change about that experience? Instead of addressing all of those things, now I'm going off of what the recipe for treating depression says, and I think there's a lot of problems built into that inherently. One, it might not feel as meaningful to you, might not feel like this is about your life and the things that are important to you. But two, if the diagnosis recipe is off a little bit, then this isn't even what's going to be helpful for you. This isn't going to treat what you're going through. It's almost like with COVID, how, we have seen the long lists of symptoms of COVID, right? Like I remember there was a time period where everyone would joke, anything your body does means you have COVID. If you coughed, if you sneezed, if you blinked too many times, that's a sign of COVID. That's obviously a joke, but if you go off just symptoms alone, it'd be really hard to know what is COVID and what isn't COVID. Some people have fatigue, some people have chills, some people have shortness of breath. But the way they actually test for COVID is through biological means. When you take a COVID test, they're testing for the presence of things in your body that say you have COVID. We can't really do that for our diagnoses. We have to go off of a collection of the symptoms, which, like we were just saying, sometimes might not actually get the picture totally right.
Yeah, I think one of the things that's really important too is, again, kind of going back to this idea of evidence-based practice, right? Evidence-based practice is based predominantly on empirical evidence. And what that means is it's all about generalizability, right? It's what do most people experience? And so if we look at those symptoms, right? If we say, well, most people have shortness of breath. Well, then if I don't experience shortness of breath, I'm going to say, well, I don't have COVID, right? And similarly, if we're looking at depression, if we say, one of the symptoms is you used to find joy in an activity that you no longer find joy in, then one of the things that can happen is if I still find satisfaction, I may not feel like, oh, I have depression. So I might minimize that experience.
Right.
Or the reverse could be true, right? If I do have shortness of breath, I might assume that it is COVID. And the reality is maybe I just have hay fever or allergies or something far less serious than COVID. And similarly, if we go with mental health, if I have a symptom of maybe I'm not enjoying something that I used to enjoy, maybe that just means that I'm going through a life transition. Maybe that means that I'm sad because I lost someone recently. Yeah. So there could be so many other explanations for this. And so if all we do is rely on evidence-based treatment, we might overgeneralize or undergeneralize, but either way, it's going to impact the accuracy with which we're providing treatment.
Right. And on the subject of accuracy, in statistics, they say things like, every individual is the exception to the rule for that group. And that works out in a statistical sense, but in a personal individual level, when you're talking about real life circumstances, it doesn't really work out for that one person, at least. So for them to feel like they're the exception to this thing that they're being defined by, I could see how that discrepancy could lead to either being misguided in your treatment or feeling like maybe you're trapped in a box that doesn't really totally fit you. But either way, like we said in the beginning, it's limiting. This is cutting you off from what could be possible.
Yeah, I think another really important consideration here is cultural differences. Right. There is a small segment in the back of the DSM, which is the book that contains all the diagnoses that talks about culture, but it's an addendum to the rest of the book. Right. And I think in an era where we're looking at racial differences in a way that we've never looked at them before, in an era when we're looking at sexual orientation differences in a way that we've never looked at them before, to say that all people experience depression in this list of ways, right, or to say that if you have these things that we classify it as depression, in some sense, that's probably an overgeneralization that minimizes, like you mentioned, individual differences, but also cultural differences. Different cultures expect different things. Different cultures provide different things. Different cultures rely on networks in different ways, all of which impact how a person's functioning. And I think that one of the limiting factors of diagnosis is that we oversimplify how culture has an impact on how we live our lives, how we experience joy, how we experience life. And it would be really detrimental, I think, to value a list of symptoms over someone's individual nuanced cultural experience.
Yeah, I'm glad you mentioned that, because that is something very much worth keeping in mind. Whenever you start to talk about something based off of a medical model, I think, especially in Western healthcare, some follow-up questions should be about how it tends to cultural differences, because I think Western medicine has had a long history of being a bit blind to those sort of things. For the sake of empiricism, it kind of washes those things away. And we know that that's important to keep in mind. The other thing that I was going to add about just another one of the potential limitations is, in some sense, and I know this isn't always the intention of a clinician, it can be a bit dehumanizing to put this label onto someone and put that label on their experiences too. I'm having a hard time keeping up with work. I'm having a hard time expressing myself to family members, and my energy levels just feel so low. The things that I enjoy don't really bring me as much joy. And there's a risk in saying you have this thing we call depression, or whatever the label is that you might take from the DSM. And now it's no longer your experiences are a function of their context and your life and what's going on for you. And nothing feels like it's actually a functional, reasonable reaction to something. Now this is a glitch in your prosperity, and this is a glitch in the functioning that you should be having. And I think, while some people might find comfort in knowing here's a name for what I'm going through, I think there's also a trade-off. You lose a bit of, of course I would feel or respond in the ways that I'm responding. It's because life is hard, and the things I've been through have been hard. And so this is, me exuding the hurt that I'm going through. This is, there's something human about the experience that you're having that I feel like the humanness can be taken away a little bit when you say, oh, you're a bit broken. This is off about you. Here's what's wrong with you, and we're gonna fix that thing.
Yeah, I think that's a really important component, and I think alongside of that, that if we view people as they have, right? So we shifted. I think a long time ago we shifted from, you are schizophrenic or you are depressed, right? So that language has softened a bit to, you are a person who's dealing with depression, or you are a person who's dealing with schizophrenia, or those kinds of things. And I think that softening in and of itself says perhaps this isn't completely fitting with who we are as people. So I think there's that. But I think in addition, if we don't go to one step further of softening, I guess, right? If I don't say I'm a person, in some sense, who's experiencing life, I think so much of mental health, right? We now are starting to talk about mental health as, oh, that person is suffering from mental health issues. And I think what that does is it separates that person from normal everyday life. And I think it's completely part of our human experience to feel sadness. It's completely part of our human experience to feel anxious. It is part of our human experience to feel like a portion of me is divided from the other portion of me, right? To say and we even incorporate that into there's a part of me that wants this, and there's a part of me that wants that, right? So so many of these diagnoses are really indicators of the human experience. And I think that when we relegate them to mental health issues or things that are wrong with someone, even if we've separated it from the person, they're a person dealing with that. I think what we inherently do is we make their life experience less valuable or less meaningful or less purposeful. And we relegate them to a different category. When I think if we as mental health professionals could say, your experience, something that is part of human experience, now I can deal with that in a way of expanding possibilities to say, so if this is a normal part of life, how do other people get on with life? How do other people manage to feel this way and still be successful or thrive in some way? And all of a sudden possibilities come instead of limiting, like now I'm this kind of a person.
Yeah, I think that is a brilliant point. I mean, we've seen in the history of psychotherapy and psychology in general, what roads you can go down when you do this dehumanizing act of this person has this problem, they're this kind of a person, they belong to this group. And across history in psychotherapy, you see how they would just dismiss people as being stuck in that problem. So now you need to go to this sanitarium or whatever they used to call them. They would just discharge them to these places. You're a broken person, now you belong there. Or even in extreme cases, they would do things like lobotomy and shock therapy and say, we need to remove and fix this part of you. That's how broken you are. But what you're saying is that these are extensions of the human experience, and if we treat them as such, it actually gives us more opportunity to grow past them and get to a better place, a more satisfying place.
Yeah, I think another component is like what you were kind of alluding to a bit is throughout history we have marginalized people because of difference in other ways, right? In race or gender or whatever. And I think in a very similar sense, we're marginalizing people who have symptoms of a disorder. And I think in a lot of ways, we're treating them very similarly to people who have committed a crime, right? In essence, we've said, you're a criminal. So now you have to go to prison, you have to go to jail. There's no reform for you. That's it, right? And that one act or that one series of acts becomes the totality of their citizenship. And I think in a very real sense, sometimes we do that in a mental health sense, as we say, if you've experienced this set of symptoms, or if you have had this for a duration of time, that becomes the totality of who you are. It becomes how we need to interact with you. And I think that's a very marginalizing perspective to encounter people.
It is. When you frame it like that, it becomes very clear. If you have anxiety, depression, suicidal thoughts, any of these things, that is a stamp on you for the rest of your life. That's your healthcare providers will be asking about that. If you try to get a government job or armed forces kind of position, they're all going to be tracking and keeping track of, asking about those kinds of things in this kind of way that you're saying that, it's defining your citizenship almost. Well, I think it would be a very valuable thing to turn and say, well, what's the alternative or alternatives? What can we do instead of or in place of these diagnoses, and why is that a better thing?
Yeah, I think that's a really valuable question, and I'm going to go back to, we did just a really small kind of research examination, right? And we looked at genuine, real clients who came, and we asked them two questions. We asked them, what brings you here? And we asked them, in essence, what are your best hopes? What are you hoping to get from this process? And it was interesting because I would say about 70-ish% said things like, I have depression or I have anxiety. When you ask, what brought you here? They reduced their experience to those specific diagnoses. When we flipped that and we said, what do you hope? What are your best hopes from this process? We got a whole range of possibilities. We got like, I want to be more self-confident. I want my relationships to be better. I want to feel good about myself. I want to feel happy. I want self-esteem. I want better communication. And the problem was not connected to what their hopes were at all.
Mm-hmm.
Their problem was really, like we had mentioned before, really limited. They fit into certain categories. Mm-hmm. But the possibilities of what are you hoping for were broad and were extreme. And I think that's one of the things, I guess, that I would advocate and that Solution Focus does so well, is it says, despite what your problem is, what you're currently experiencing, what symptoms you might have, if treatment goes well, what do you hope would happen? And then we move toward those hopes, right? We say, and if you found more confidence, or if self-esteem all of a sudden was going up, if you experienced more happiness in your life, what difference would that make to you? And again, if we go back to the brain, the more we talk about those possibilities, the more we talk about those positive emotions, the more those other symptoms seem to take care of themselves. We don't have to attend to the problem at all, but we can totally attend to what do you hope? And then they get better. They move in a direction of helpfulness.
And that is such a fascinating thing to me. And it says a lot, I think, about mental health, but also just, human beings in general. One, it says that we don't have to be defined by our problems. The things that we want, the things that we need, the directions we can go in that would be good for us, don't necessarily have to be dictated by what happened to us. Who are we as a result of our problems? What identity is this diagnosis trying to place onto us? The other thing that it says, though, is that there is something inherently helpful about embracing the thing you're trying to move toward. As you know, I spent some time working with refugees and asylum seekers. And trauma was ubiquitous. It was everywhere. It was all the time with all these clients. And often when they first came in, there's a long list of the things they can't do because of their trauma. I don't like to go to these kinds of places. I don't like to talk about these kinds of things. I don't like to think about this or be here. And what you would find as they were progressing through their treatment was a turn towards what you're talking about, this approaching behavior, this moving towards the things that they want and the things that they can do and that they want to do. And it wasn't ever necessarily defined by what happened to them, what country they came from, the things that they did and the things that triggered their trauma. This was now, I want to be this kind of a person. I want to have this kind of a life. And all the steps that I take towards doing that are implicitly helping me with this underlying mental health problem. But explicitly, it makes me feel like I'm being the kind of person that I want to be.
Yeah, I think that's so valuable. And if we go back to that analogy of medical problems versus mental health concerns, in some sense, if I went into my doctor and they said, what do you want to do? And I said, I want to be a runner. Then they would say, okay, we got to fix that leg, right? That broken leg is going to get in your way of becoming a runner, right? But that analogy doesn't hold up in mental. We don't necessarily have to fix a broken leg, but in some sense, they become reciprocal, right? I can become somebody who is, let's again make the analogy from running to confident, right? I want to become a confident person. If I say, what would it look like if you became confident, and who would notice that you were becoming confident? And one of the things that we understand is that person, as they describe confidence, they start to take on the characteristics of competence. And simply by describing what they want, they begin to inherently address the concerns that they've got. So that's where I think, again, that model of diagnosis may not fit so well within a mental health, because we don't have a broken leg to fix. We know that if we move toward where we want to go, that momentum, that forward progress inherently addresses some of the concerns that I came in with.
Yeah. What you're describing, and I only recently, I think, started this kind of language to it. What you're describing to me sounds like the biases that we build up for how we interact with the worlds that we're living in. And if you go at it from this medical model diagnostic angle, you get really, really good at having a bias for seeing the symptoms, seeing what's wrong with you, seeing why you fit into this category. And then you keep your eye on that and you watch those things. But when you take this other side, like you're saying, this other approach, it can build up this bias for how those things are possible. How does confidence even show up? And it gets your eye really sharp at, I'll catch it when confidence shows up. I'll see all the things that tell me confidence is showing up, when otherwise I might miss it, even if the same things showed up, because I'm looking at depression. I'm looking at, anxiety. What's wrong with me?
Yeah. I think it's, kind of boil all of this down, right? I think, again, this topic fits so well into the theme of possibilities. Yeah. If we solely view mental health as a series of diagnoses, we significantly limit not only individual possibilities, but we limit human capacity, right? And I think that if we can take a different approach and we can say, it might be much more useful for us to be hope builders instead of diagnosis fixers. Then we expand individual possibilities, but we expand possibilities at a global level. That sounds probably idealistic, but think about the amount of money that gets lost on people who are suffering from mental health. Think about the amount of money that insurance companies pay to fix mental health. There's a lot of research that says when we help people in this way, in this hope-filled way, they get better quicker. They stay better longer. And I think that the reality is we would be fixing so many other concerns, right? If we could start viewing each other as capable, as hopeful, as bigger than individual human experiences that are happening to us in this moment.
Yeah, exactly. I don't want to even ruin that description. I can't put any better words to it. So I think that's exactly it.
Well, thank you so much. I know that this is a really controversial topic that we've taken on today. We would love to hear your thoughts and reactions to our impressions about the potential limiting of possibilities that come by a reliance on diagnosis. So send us some comments, like and share if you feel like this is a conversation that needs to be shared with others out there. We would love to hear what the bigger conversation could include.